Okay, I think we'll make a start. Good afternoon, everyone, and thank you very much for joining us today for this webinar. My name is Judith Rankin. I'm Professor of Maternal and Child Health here at Newcastle University, and along with Dr. Aquino, excuse me, we co-led this evaluation, and you will be hearing from Rice later. So our webinar is entitled Supporting Maternal Health in the North East and North Cumbria, Findings from a Regional Public Health Prevention in the Maternity Programme. And we're really keen today to share with you the findings from this evaluation and some of the recommendations that we've made, specifically around three areas: mental health, reproductive health, and maternal healthy weight. But before we get started, just a few words of housekeeping. So hopefully there won't be any fire alarms and we won't have to vacate the building or etc. But just to say that this will be recorded and will be made available on the ICB and the Applied Research Collaboration websites. We really would welcome your questions and comments, but please could we ask that we do this towards the end. We have got some time set aside for our Q&A, but you're welcome to start adding your questions to the chats in the Q&A function. But we would also be very happy if you'd like to raise your hand and come off mic and ask your question when we get to that stage. I think that's all the housekeeping that I wanted to remind people of. As I said at the beginning, we have a lot to get through, so we'll crack on. And I would like to introduce our first speakers, David Gardner, who's Public Health Consultant in Health and Wellbeing in the Office for Health Improvement and Disparities, and Becca Scott, who is Clinical Lead and Head of Public Health, Women's Health and Best Start in Life for the North East and North Cumbria Integrated Care Board. I'll pass over to you now. Thanks.
Thank you, Judith, and good afternoon, everybody. My name is David Gardner. I'm a consultant in public health in OHID, as introduced, and it's been my pleasure to work with Becca and the team, Judith, Rice and Caitlin and other colleagues in relation to this programme for a number of years now. So I have been part of the governance and oversight of the Public Health and Prevention Programme since its inception in around about 2018, and we've worked through its various iterations to provide some support from a public health specialist lens, working hand in glove with directors of public health and colleagues in the LMNS too. Can we move on to the next slide, please? Thank you. Okay, so the programme's aim has always been, of course, to focus on increasing the public health focus within perinatal services, looking there to improve outcomes and to reduce health inequalities at the same time. The programme under Becca's leadership has provided clinical expertise in prevention and has worked right across the perinatal period, always looking to enhance the work that was being delivered at place, adding value to work that was already there, learning from colleagues within the system, sharing good practice efficiently, and with a real spirit of collaboration. Increasingly, the programme has become integrated within the North East and North Cumbria's health architecture, working alongside key partners and including good links with national colleagues too, who remain interested in this latest piece of research and the findings. So we'll look forward to sharing that in due course. Thank you. Next slide, please. So the team, of course, have done all of this work in partnership, and grateful to Becca and colleagues who've developed this slide by way of illustrating the scope of their reach, colleagues and teams that they've worked with, topics of interest as well. So I won't go into that in any detail, but of course the slides will be shared afterwards. The key point here is to note that all of this work has been built on partnership. Thank you. Okay, so from the beginning, there were several areas that we termed must-dos. Colleagues will be really familiar with these as public health priorities. So tobacco, alcohol, breastfeeding, perinatal mental health, healthy weight, immunisations, making every contact count, and more recently, reproductive health was also added as a priority for the programme. And on the right-hand side of this slide, you'll see a number of evidence-led approaches to change and influence that the programme has always sought to make best use of, not least of which includes research. So once again, that brings us back to the purpose of today, and it's been a privilege to work with our esteemed colleagues who introduced the call, and I really look forward to hearing more about the outcome of this and having some good discussion with colleagues on the call who've joined us today. So the next slide, I believe, is going to be some of the early successes, and I'll hand over to Becca now to take you through that. Thank you.
Brilliant. Thank you, David. And again, thanks for today. It's a really important piece of work, and I think we've got a lot to learn from this piece of research. So as introduced, my name is Becca Scott. I have been leading the programme for 7 years since its inception in 2018. And now I'm just going to take you over the early successes of the programme. Through the engagement that we had right at the beginning in 2018, that has really led the way and the foundations to where we are now. And some of those early pieces of work was finding who else is working in the same area of expertise. So quite naturally, it was around the public health midwives and bringing them together to make sure that we had that peer-to-peer support group, but really a robust group of people that we could cascade the messages and work together to get the best for our system. From that, we were able to develop public health plans. We work really closely with maternity voices who are now maternity neonatal voices partnerships and their lay representatives across the region to make sure that everything we were developing worked well for women and families. And from that, we were able to develop pathways, strategies, best practice guides, recommendations, tools, training. And you can see a few of those dotted onto the screen. And that's the original Public Health Midwives group back in 2018. And it has just gone from strength to strength. Move on, move it to the next screen. So continuing that success, we've had to really build upon what are our weaker areas and the gaps that we have in delivering pathways and tools and an offer to pregnant women and families. And that looked at training. So we've made sure that we do have high quality, consistent approaches using the evidence. And where there has been a gap, we've worked with expertise in those topic areas to develop something that's going to be useful for practice. So for example, alcohol in pregnancy was a gap, and that's been developed and that's been shared nationally and is used in other areas as well. It's quite successful. Where there's cross-cutting initiatives needed, as you can imagine, a lot of the work that we do, it interrelates with other parts of system working. And so it's been able to identify what are the gaps and what can we do to support it. So, for example, we've improved the data collection, which doesn't just affect the work that we undertake, but it affects other parts of the system to develop. So we've got the Public Health Prevention Maternity Dashboard, which you can just see on the top corner of the screen. That's been really useful. We've supported the LMNS with their equity and equality report by undertaking the health needs assessment and setting that kind of format out of how do we approach that with a public health approach and offering some real insight there around the modifiable factors elements. We've undertaken social media campaigns and they've been very targeted to the populations that it would be best landed with. We undertake the review of the Red Book and coordinate that for the North East and North Cumbria. We've done work on the Pregnant Migrant Toolkit for healthcare professionals. We have a poverty proofing approach, and we are really keen on health literacy approaches as well to make sure that the information that we're sharing with women and families is understandable, essentially. So whilst we recognise that it's really difficult sometimes to be able to measure how the programme has really delivering and having an impact on outcomes, we really need to demonstrate that we are reducing the inequalities, and some of the key areas in terms of data that we can demonstrate that I'm just going to take you through now. But ultimately, what we've noticed over the last 7 years, that there's been a real shift in focus from individual organisations delivering components of maternity care to a whole system approach. And this is it really embedded in communities. And we've got those robust regional pathways and practice innovations to make sure that the best care is offered at the right time in the right place. And as I said, sometimes that is really difficult to demonstrate in terms of data, but to be able to shift the dial on things like the smoking and time of delivery has been really beneficial, and it is coming back to that partnership working. So that's been one real key area for us. And with tobacco, we've had the pathway. We made sure that we had senior executive support back in 2019. It kept it really high on the agenda in trusts, and working with our directors of public health as well. We were able to secure some funding for a maternity incentive scheme that started in 2022 as well. And we feed our learning into the national developments. And fortunately, that's being funded from a national perspective now as well. And this has resulted in the reduction of smoking in pregnancy. And, you know, we're expecting rates in about 2 weeks' time. We are really hopeful that we'll have had the lowest rates yet. And not only that, it saves such a lot of money to the system, not just to maternity, but we know for maternity services in the East and North Cumbria, for 1 year alone, reducing smoking in pregnancy between 23 and 24 had a saving of over £1.8 million. So it pays as well to have this approach. Another key area was around the infant feeding, so particularly breastfeeding. And if we look at the breastfeeding rates, we know that they have increased, and the robust area of data for breastfeeding is around the 6 to 8 week period in the community. And that's significantly improved for us in the North East. So we went from 21.7% at the beginning of the programme to 35.6%. So this is really helping, having those consistent approaches, accreditation of UNICEF, it's having a great impact. So I suppose just in conclusion, to summarise, this programme is working well. It's a public health approach. It does take time to see the results of the work that we're undertaking. We need to continue to work on the successes that we've had, and need to think, how does the programme work now as the ICB is changing and what the offer is, but also thinking about newer areas of work potentially and learning. And that's why it was really important to us that we did have this evaluation of the areas that we actually found more difficult to embed. So I really appreciate everyone joining us today to learn a little bit more about this, but particularly to the researchers who have undertaken this, because it isn't an easy area of work to really nail down what is the outcomes. So thank you.
Thank you very much, David and Becca, for giving us that overview of the programme, but also taking us through some of those key successes and achievements. So now we are going to move on to the evaluation itself, and we're going to take you through the different aspects of it. We've got 3 contributors to this section. One who's not with us in the room, and we'll just introduce her in a moment, and then Bryce and Caitlin will introduce themselves as they do their contribution. So just a reminder before we get started with this, we're obviously very interested in your questions and comments about the evaluation itself and the findings that we did get. So please do add your questions to the Q&A. But we'll move on now and start with Jasmine.
No, I'll set up the methods first.
Oh, right. So we're familiar with it. I'm going to hand over to Bryce, who will introduce herself and also take you through the methods for the evaluation.
Great, thanks, Judith. And thank you, David and Becca, for setting up the scene so clearly and wonderfully. It's been great to work with you guys on this over the last number of years, and thank you to everyone who's attended today. I'm really happy to share with you some of the findings that we've got from the evaluation of the programme. So as Becca kind of talked through, there have been, several key achievements from the programme. And we're trying to build upon here beyond kind of smoking and breastfeeding, etc. So our evaluation, which was commissioned in April 2023, really aimed to assess the impact of the programme on health and care outcomes across 3 specific areas. So you have perinatal mental health, reproductive health, and safe pregnancy spacing, as well as maternal healthy weight. And throughout this, we've applied an inequalities lens. And we chose these areas because these were the areas that had least evidence to date at the time. So in terms of our evaluation, we undertook a multi-method approach in 3 parts, and we undertook a document analysis, which Jasmine will present on in just a moment, and then we also undertook some exploration of routinely collected data through different data sources, and finally we also undertook some qualitative interviews with professionals as well as parents. And so it was really important to link these different methods and approaches to gain a deeper understanding of the impact of the programme drawn from different data sources. So for the document analysis, we'll just briefly introduce Jasmine. She was one of our Masters of Public Health placement students who's originally from Canada, so she's pre-recorded her presentation all the way from Vancouver, and we'll just play that now. Okay, so I'm now going to move on to some of the quantitative findings that we've derived from our exploration of our routinely collected data. So just as an overview, we observed several key indicators that were related to our 3 priority areas here. I'm not going to read each of these indicators, but we followed essentially what is an observational design. We used routinely collected aggregate data that's been sourced from the North East Commission Support Unit, for example, the Public Health Resident Maternity Programme dashboard, the DHSC fingertips dataset, as well as the Maternity Services dataset. Just to put the quantitative findings that I'll be presenting into context, just to let you know that the analysis that we undertook was largely descriptive, and we tried to look at some trends over time where this was available, as well as across areas of deprivation and ethnicity, again applying that inequalities lens. In terms of the time period that we looked at, we focused on the time before and during implementation where this was possible. So this is quite varied across these 3 priority areas and the indicators that we looked at. Finally, to put these findings into context, we were unable to directly attribute any of the specific outcomes in relation to the programme itself. However, this gave us some really useful informational context to help us with our interpretation of the findings from the other aspects of the evaluation. So just to give you a bit of a profile of the mothers throughout this evaluation period. So in terms of the demographics, between 2021 and 2023, there were over 60,000 booking appointments that were recorded. And over 1 in 5 of these bookings, women lived in the most deprived areas. So these were people that were living in areas where their index of multiple deprivation score was below 5. And in particular, there were over 13,000 booking appointments from IMD score 1, so which is the most deprived areas. In terms of the ethnicity of these women, it was a majority white population, which is quite similar to the population demographic within our region. So for perinatal mental health, we had observed some of the data between 2020 and 2024, focusing particularly on the most recent data in October 2023. Almost 4 in 10 pregnant women had a diagnosis of anxiety or depression recorded from their primary care records. Most women self-referred, and over 1 in 10 women were referred through primary care. The majority of these referrals were for those living in the most deprived areas, again with index of multiple deprivation scores of below 5. What I've done in the next slide is to overlay some of these findings around access to perinatal mental health services. So in the previous slide, we had the number of referrals which approached 3,000. And on this slide, in orange, I've overlaid the women who have accessed services. So in 23-24 in particular, you can see that close to 2,200 women had access to perinatal mental health services within 28 days of referral. And again, we're seeing an increasing trend here in terms of both referrals as well as access to perinatal mental health services in our region. In terms of reproductive health and safe pregnancy spacing, there has been an increase in the average number of days from birth to booking for a subsequent pregnancy between 2020 and 2023. And this has been on average a 28% point change in increase in days over this 4-year period, which translates to an average of 17.4 months between bookings for another child by the same mother. For Healthy Start vouchers, there were over 30,000 individuals that were eligible for Healthy Start vouchers between January and December 2023, and the average uptake of these vouchers was 72% in that year. We did attempt to look at some abortion statistics, and we experienced some challenges to kind of understanding the recording of abortion data across the data collection period, given the changes to how our region has been categorised over a different number of years. So the catchment populations had kind of changed slightly. Finally, in relation to long-acting reversible contraception prescriptions, or LARCs, we found an absence of regional level data, but using kind of national data, there has been a decline in the prescriptions of these. Finally, in relation to maternal healthy weight, in Q1, which was between January and March 2023, using local data, we had found that 71% of bookings had a body mass index or BMI recorded. And using the National Maternity Services dataset, it has been reported that all trusts across the region had recorded that 6 in 10 women at 15 weeks gestation fell into what's called an at-risk BMI group, and these at-risk groups are classified under overweight, obese, or severely obese, and this is much higher than the English average. Finally, in relation to maternal healthy weight, between 2021 and 2023, 3.8% of women had been diagnosed with gestational diabetes, and this has increased by almost 2% when compared to 2019 and to 2021. I'm going to hand over to Caitlin now to talk through the qualitative findings of the interviews with healthcare professionals as well as parents.
Thank you, Rice. Yes, hi everyone, my name is Caitlin Thompson and I'm a research assistant who worked on the qualitative elements of the evaluation, and I'll be presenting those findings.
Yeah.
Thank you. So as mentioned, we did collect qualitative data from one-to-one interviews with parents and professionals, and details of those interviews are on the slide here, and we analysed those interviews using thematic analysis. So in total, we interviewed 32 parents, and there's some demographic information here, but please do have a look at the full report for full demographic details. I've put a link to the report in the Q&A function. And from our interviews, we identified 4 themes, which I'll kind of touch on briefly, but again, for full themes, sub-themes, and quotes from participants, please have a look at the full report. Thank you. So firstly, parents referred to elements of general care delivery which help to facilitate the delivery of PIPIM as a programme. And when I say PIPIM, I'm talking about the Public Health Prevention and Maternity Programme. For example, continuity of care with health visitors and midwives helped to improve rapport, and it made parents more likely to engage in conversations around mental health, contraception and healthy weight. Could you just scroll down? Sorry. Thank you. And participants also highlighted that involving partners in care could help to improve or facilitate discussions around family planning, as well as promoting general care experiences. And many participants reported that there was a general need for access to services, so improved access to community groups, and also access around travel and timing of appointments. And for the 3 priority outcomes of mental health, healthy weight, and reproductive health, we identified barriers and facilitators across all of those outcomes. So for mental health, barriers included women feeling like their physical health was prioritised over their mental health, and a general lack of or limited antenatal mental health checks and referrals. Participants also again stressed the importance of rapport building and having conversations around mental health, and women also commented on how signposting to available services was helpful, such as the birth reflection services. And for healthy weight, women again stressed the importance of individualised care and adjusting conversations to each person's circumstances. Women who were diagnosed with gestational diabetes found that they were offered sufficient support during pregnancy, but some may like some better support after pregnancy, such as help with meal planning and sort of advice around. Down, please, thank you. And for reproductive health, participants stressed the importance of individualised circumstances and context when discussing postnatal contraception, and sort of considering how women's different contexts could affect how suitable the standard discussions around contraception were perceived. But on the whole, women reported that postnatal contraception information was accessible and readily available. For providers, we interviewed a total of 18 healthcare professionals and providers of the programme. Again, there's some demographic information on there, and we again identified 4 themes. So we identified strengths of PIPIM as a programme, both as an agenda and also as implementation. So for programme strengths, providers generally shared a commitment to the agenda that was set out by PIPIM, and the programme was recognised as being instrumental in bridging collaboration and shared learning across networks. In terms of implementation, PIPIM was regarded as by participants as providing a clear focus and worked as a clear guide, and also having leads on the ground, such as the public health midwives and specialist leads, was particularly useful. Staff commitment and engagement to the training was also seen as a key strength. And in terms of some challenges, participants did note that there were difficulties associated with tracking long-term outcomes made from healthy weight and mental health referrals, and also some challenges with resource meeting demands such as funding and workforce capacity. And also ensuring that the services match the diverse needs of the population was also seen as a challenge. And then the final theme related to the impact of the programme on practice and care delivery, and this was mapped across the 3 priority outcomes. So for mental health, the introduction of services such as birth reflection services and having more streamlined mental health support improved access to mental health support and training for staff. For healthy weight, providers discussed increased conversations around healthy weight with women and families, and also an increased access and uptake to specific training and services that they were able to refer women to. And for reproductive health, there was improvements noted in postnatal contraception revisions, including increased access to training and also a general increased awareness of the importance of postnatal contraception. Thank you. And then following on from our findings, we developed the following recommendations. So for PIPIM as an agenda, we recommend to continue collaborative working between local authority and NHS trusts. For example, ensuring that frontline healthcare professionals are included in the development of the agenda and actions. And also continuing the involvement of women and their pregnancy or birthing partners or significant others in developing the prevention agenda. We also recommend continuing to provide healthcare staff with up-to-date and relevant knowledge of local statutory and non-statutory services that are available for referrals, as well as developing leaders in prevention in maternity to support practice across the region. And we also recommend continuing the evaluative work of the programme and its impact using robust and routinely collected data. In terms of PIPIM and service and deliverables, we recommend facilitating further collaboration with frontline staff. For example, having a feedback loop where frontline staff who are delivering the programme can provide suggestions on service development based on their experiences of delivering the service on the ground. We also recommend facilitating training for healthcare staff to provide the necessary skills and the tools to increase confidence when discussing potentially stigmatising topics with women and families, such as mental health and healthy weight and postnatal contraception. We also recommend that we ensure that the diverse needs of the population are met across the region, and we include marginalised groups in the development of any strategies and services. And then we also recommend facilitating the incorporation and co-production of tools and advice around healthy meal planning for families. And finally, we recommend involving partners and wider families into routine care. So thank you, that's everything. I think we're gonna, the research recommendations. So yeah, we recommend prospective evaluation of the impact of the programme across health and care outcomes using longitudinal methods and prospective recruitment, so we can really get an understanding of people that are currently accessing services or delivering the care. And again, continuing the collaboration with the PIPIM team to develop data collection tools to facilitate comprehensive reporting on outcomes using both quantitative and qualitative sources. Thank you. So that's everything, and we're going to move on to the Q&A now.